So naturally, if you are pregnant, you should avoid radiation. There are certain artifacts which can falsely elevate the DEXA value, falsely elevate the bone mineral density. For example, if there is a prosthesis, a metallic implant, osteoarthritis, they might falsely elevate the DEXA value. Similarly, if there are certain radio-opaque substances, they can falsely elevate the DEXA value. Nuclear scans, even intake of calcium within the last 24 hours, the calcium tablets might falsely elevate the DEXA value. So, all with fragility fracture, 65 and above female, 70 and above male, those with high risk should undergo a DEXA scan at baseline. Now, when should the DEXA scan be repeated? Now, suppose you get a patient with a fragility fracture, you know that this individual has osteoporosis, you do a DEXA, establish a baseline, and you start treating them with specific anti-osteoporotic therapy. For example, if you start treating them with teriparatide, changes in the lumbar spine might be evident on DEXA as quickly as 1 year, but never before 1 year. The usual standard is usually to repeat the DEXA after 2 to 3 years of therapy when we are using anti-resorptives like zoledronic acid or any other anti-resorptive agent. Similarly, if you get someone who is not given active anti-osteoporotic therapy, you are following up the patient, and on a follow-up scan, if there is a loss of EMD, then you can decide on therapy. Someone who is on anti-osteoporotic therapy, for example, receiving zoledronic acid, receiving teriparatide, but suffers a fracture, you can repeat a BMD to see if things have gone worsen further. And we know that when we are using the bisphosphonates, we can give a drug holiday after 3 to 5 years when we can do the DEXA to see. Do the DEXA serially to see if things are worsening and if you need to restart the bisphosphonate. Now, every investigation has some amount of error. For example, if you repeat the same fasting plasma glucose in 3 different laboratories, you get a slight variation. Or for that example, if you do the fasting plasma glucose in the same instrument 1 hour after each sample, you might get slight variations. Similarly, there might be a slight variation with the DEXA, with the same instrument and the same operator, which is called the precision error. And after you include the precision error for a given instrument, there is something called the least significant change, which is usually considered to be around 5%. Simply put, it means that today you are doing a DEXA scan. You are repeating the DEXA scan after 2 years. So any change which is less than 5% in the repeat scan could be just because of an intrinsic error of the machine or the technologist. It need not be that there is a change in the BMD of the patient. So the change in a follow-up scan should be at least more than the least significant change, which is usually around that 5% point, to say that there is a significant change in the follow-up bone mineral density compared to the baseline bone mineral density. And when we are doing the follow-up scan, the bone mineral density value becomes important. At baseline, we look at the T-score to establish a diagnosis of osteoporosis. During the follow-up scan, it is not the T-score that we are looking at. We are looking at the absolute value of the bone mineral density. If the bone mineral density improves, or even if the bone mineral density stays the same, without deteriorating with increasing age, we can say that our anti-osteoporotic therapy is working well. Same individual underwent a DEXA scan in 2020, a repeat DEXA scan in 2024. But again, we need to be careful. As I said, there are many pros and cons, fallacies when interpreting a DEXA. It's very obvious that there is a difference in position. So simple things like a difference in position can lead to a lot of difference in the BMD value, making a repeat DEXA uninterpretable. So it's very important that the same instrument, the same operator, the same positioning should be used while doing a repeat scan, because it's an ultra-sensitive modality. There are a number of false positives, there are a number of false negatives. So we are now looking at a different patient, a 65-year-old lady who undergoes a DEXA. We are now following the guidelines. She's 65 years old. We are doing a routine DEXA. And we find that the T-score at her hip is minus 2.3. She says that her mother suffered a hip fracture at the age of 50 years. So does is secondary osteoporosis, whether she consumes alcohol. And if you put them all together, and there is an India-specific algorithm as well, you get two values. One is your 10-year risk of a major osteoporotic fracture, and the second is your 10-year risk of suffering a hip fracture. So it is said that if your 10-year risk of a major osteoporotic fracture is more than or equal to 20%, or if your 10-year risk of suffering a hip fracture is more than or equal to 3%, you treat the patient for fracture prevention. It's cost effective. We have had a study, Dr. Thomas is here with us. We had a study from CMC Vellore which said that for India, these figures will be as low as 9.5% for a major osteoporotic fracture and 2.5% for hip fracture. If your facts values are over that, you treat and you get some benefit. Of course, in someone who has suffered a fragility fracture, you need to treat to prevent a second fracture. Like in someone who has had a heart attack, you need intensive treatment to prevent the second heart attack. And of course, if your T-score is in that osteoporotic range, you need to diagnose that patient with osteoporosis and treat that patient as well. So again, calcium and vitamin D on their own has zero data for fracture prevention. It's only when they are used as adjuvants along with these therapies that you get good fracture risk reduction. If you look at these drugs, the bisphosphonates prevent both vertebral and non-vertebral fractures. Teriparatide has excellent data for vertebral fracture prevention, but good data for hip fracture prevention with teriparatide is lacking. So going back to the patient that I was discussing initially, yes, calcium and vitamin D does play a supplementary role, but this patient needs definite anti-osteoporotic therapy in the form of teriparatide because the spine is predominantly involved, or even for that matter, either bisphosphonate. And of course, a DEXA needs to be done at baseline to establish a baseline and to look at follow-up to see whether things are improving or not. So beyond the DEXA, we need to realize that for a given T-score, the more your age, the greater your risk of fracture. For example, someone with a T-score of -2.5 at the age of around 45 years has a 10% risk of fracture over 10 years, whereas someone with the same T-score at the age of 60 years has 25% increased risk of fracture. So as your age increases, for a given T-score, your threshold for treatment should be low. We also need to realize that again, DEXA is not the be-all and end-all of diagnosing or managing osteoporosis, because when you are using an anti-osteoporotic therapy for the same changes in the T-score or the BMD for that matter, there could be different rates of fracture prevention. In patients with diabetes, often the BMD report is normal, but the risk of fracture is increased because the microarchitecture of the bone is damaged. We now have other scores like the trabecular bone score to look at the microarchitecture of the bone, but I believe it's beyond the realm of discussion today. I would like to end with the saying that the biggest mistake that we make in osteoporotic management is to wait for a fracture to occur. We shouldn't wait for the heart attack to occur before managing cardiovascular risk factors. Similarly, we should use the DEXA more often, we should use the FRAX more often, and prevent that first fracture and diagnose osteoporosis before it occurs. Thank you.